So we are going to present a case of Mrs. X, 71 years of age, female, who is a homemaker by occupation, staying in Kulashekaram, belonging to upper middle class according to modified Kukuswami scale. Came with chief complaints of cough for the past 2 months, chest pain for 7 days, and breathlessness since 15 days. History of presenting illness: the patient was apparently normal 2 months ago. Then she developed cough, which was insidious in origin and progressed to 7 to 8 episodes per day. It was not associated with sputum production. She had chest pain 2 months back, which lasted for 5 to 7 days. It was left-sided, catchy type. It would aggravate on taking deep breath or coughing and was partially relieved on lying on the left side. For the last 15 days, she complains of breathlessness. Initially, it was present while walking upstairs. It rapidly worsened, and now she is having breathlessness even during day-to-day activities. That is grade 4 dyspnea according to MMR rating. It was aggravated on lying on the right side and partially relieved on lying on the left side and on sitting position. There is no history of orthopnea or TNT. There was history of loss of appetite in 2 months. She also complains of significant weight loss in the past 2 months. There's no history of fever, no history of night sweats, no history of evening rise of temperature, no history of blood in sputum, no history of bone pain, no history of hematuria, no history of trauma to the chest at any time. Past history: she was diagnosed with renal cell carcinoma of the left kidney 1 year back, for which she had undergone nephrectomy. She's a known case of hypertension since 8 years and is on regular medication. She's not a known case of diabetes mellitus, bronchial asthma, epilepsy, or thyroid disorder. No history of tuberculosis in the past and contact with TB patient. Drug history: no history of any drug allergy. She's on regular medication for hypertension for the past 8 years. Personal history: the diet is a mixed diet. Appetite was reduced since 2 months. Sleep is normal. Bowel and bladder habits are regular and normal. Not a known smoker or alcoholic. Family history: no history of TB, bronchial asthma, or malignancy in members of family. Summary: a 71-year-old Mrs. X, who was operated for renal cell carcinoma 1 year back, who is hypertensive on regular medication, came with chief complaints of pleuritic chest pain on the left side 2 months ago, which lasted for 5 to 7 days. Cough, loss of appetite, loss of weight for the past 2 months, breathlessness in 15 days, rapid worsening and trypopnic in nature. Possible system involved is respiratory system.
General examination.
What is your inference? How did you come to this conclusion?
The patient initially had cough, and then she developed chest pain initially, then it got relieved after a few days, and then it progressed to breathlessness. And also the patient is having a past history of renal cell carcinoma, so mostly I suspect a metastatic origin in the pleura, and which resulted in pleural effusion, sir.
Which side pleural effusion are suspecting?
Left side, sir.
Why do you suspect left side pleural? Because he had pain on the left side, isn't it?
Pleuritic pain he had on the left side, and he had breathlessness also, and it got relieved on lying on the right side.
So she has the longest duration of symptoms 2 months.
2 months.
Which is cough.
Cough, sir.
Then chest pain.
Then she developed chest pain. Then breathlessness.
7 days.
15
Start
days.
the cough. Then
Chest
chest pain.
pain
Chest pain
initially.
now reduced, now the breathlessness.
Now breathlessness for the past 15 days.
And you mentioned in the summary that it is pleuritic chest pain.
Yes, sir.
When did you say it's pleuritic pain, or why did you say it?
So in this patient, the chest pain got aggravated on coughing or in inspiration, sir, and it got relieved on lying on the same side.
So what's a typical pleuritic pain? Anyone? So lung has no pain innervation. No? So whenever a respiratory disease manifesting as pain, what is the message? That is painless. It has no pain innervation. Either the pleura, the parietal pleura is involved, or the chest wall is involved. Here there is a patient who has 2 months of cough with a background of renal cell carcinoma operated. After 1 year, she developed 2 months cough. Gradually, she developed chest pain. Now the pain disappeared gradually and breathlessness started. This is the classical history of a particular disease. My question is, what is the typical pleuritic chest pain? Sharp, pricking or catching type of pain. It aggravates during cough is deep inspiration and relieved by
Lying on the same side.
lying on the same side. Okay. And gradually the pain disappears. So what would have happened?
Pleural effusion.
So pleura, actually because of the pleural inflammation or pleurisy, the pain was there. Gradually the fluid came and the two layers of pleura separated, and as the fluid quantity increases, the patient feels breathless. So we can assume that the patient developed cough and gradually there was a pleurisy, then fluid accumulated and breathlessness. Classically fever was absent. No, when you label pleurisy, the first thing when comes to mind is a pleural infection. So which should have, the patient should have had a fever. So the absence of fever is giving a clue. Presence of pleural chest pain gradually disappeared and then breathlessness started indicating that there may be pleurisy of non-infective etiology started. Gradually the fluid increased and the patient became breathless. In that background, what is your possibility? From the history.
Because she had an RCC 1 year back and she had undergone nephrectomy. So my possible diagnosis metastasis to the pleura, which resulted in pleural effusion, sir.
So how will you explain the cough if it is a pleurisy and pleural effusion? So your possibility is very good, very good. You thought of a pleural pathology. But pleural pathology is a disease of the pleura. But the main complaint is too much cough. Did you notice that? Sir was telling now when cough is there, either the pancreas or the airway is involved. When pleural chest pain, pleura is involved. Breathlessness can be to either. It can be to the lung disease or to the pleural disease. So here there is a patient with a 2 months history of cough, followed by chest pain, then breathlessness. So if you say pleural pathology alone, something remains unanswered. Finally, after examination, you make a diagnosis of whatever it is. But now, history, what is the reason for the cough?
So there is irritation to the pleura and also the dry cough. That means the lung parenchyma is not involved. So basically, this kind of pleurisy which is causing the cough.
So what is your opinion? She is concentrating on the pleural pathology because I know that she knows the diagnosis. There may be patient, undiagnosed patient will be given for your examination. The examiner will quickly ask if the patient has 2 months of cough. And when there is more than 2 months of cough, 2 weeks you have to suspect even tuberculosis. So I am asking, is the lung free or the airways or the parenchyma is involved?
Sir, it's a non-productive cough actually, and also it's not associated with fever, not associated with evening rise.
Or is it better to say pleuroparenchymal disease now? That can explain everything. Rather than confining strictly to the pleural disease. But we don't know, we know only the history. We are going to examine the patient. We don't know whether he has some COPD component causing cough, we don't know. Whether he has a lung metastasis and subsequently pleural fluid due to malignancy, we don't know. So it's better to say when you say pleuroparenchymal disease, that can explain all the symptoms of the patient. That will be a tricky way of explaining everything.
Yes, sir.
So the cough can be due. Finally, we may tell that this is pleural effusion. But at present,
From the history, you have to say it like that.
that's a possibility. From there, what possibility you said is a lung manifestation second to the renal cell carcinoma. One possibility. Other possibility is history you cannot confine to one possibility. You have to have more possibilities.
It's in view of this.
2 months cough, chest pain,
It
and
can be TB, sir, because
it
it's
can be tuberculosis. Tuberculosis is also a pleuroparenchymal disease usually. It can involve the lungs. Simultaneously, pleural effusion also develop. And more than 2 months of 2 weeks of history, tuberculosis is a possibility. Okay.
That's a chronic bronchitis. It's cough is there.
2 months of old age ready, possibility of a chronic obstructive pulmonary disease may be complicated. That's also a possibility, even though it's there, a lot of negative points are there. So that can be also considered. So we will keep 3 possibilities. Number 1 is a pleural effusion or a parenchymal which is secondary to the renal cell carcinoma. Pleuroparenchymal manifestation of the previous carcinoma. Number 2, pulmonary and extrapulmonary tuberculosis. Pleural effusion and parenchymal tuberculosis. Number 3 you said maybe a chronic bronchitis. And now we go to the examination.
Central examination, Patient is conscious, oriented to time, place and person and moderately built and nourished. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy and no fetal edema. Vitals, pulse 64 beats per minute, regular rhythm, normal volume, normal character. BP 110 by 18 mm mercury measured in right arm in supine position. Respiratory rate 28 cycles per minute. Type of respiration is thoraco-abdominal. A febrile and weight is 62 kg. Height is 156 cm and BMI is 25.42 kg per meter square. Examination of respiratory system. Inspection, examination of upper respiratory tract. Nasal cavity is normal, oral cavity is normal. On inspection, trachea appears to be deviated to right. Examination of chest, shape, elliptical shape. Symmetry, slight bulge in the left side. Intercostal space widening is present. Chest movements appears to be reduced on the left side. Apex beat cannot be visualized. No use of accessory muscles of respiration. No dilated veins, scars, sinus. No visible pulsations. No kyphoscoliosis, drooping of shoulder. Palpation. Inspectory findings are confirmed by palpation. Trachea deviated to the right. Apex beat not located. Intercostal space tenderness absent. Palpation. Measurement. Anterior posterior diameter is 30 cm. Transverse diameter is 38 cm. Chest circumference on expression is 96 cm and chest expression on chest circumference on deep inspiration is 98 cm. Chest expansion is 2 cm. Right hemithorax expansion 1.5 cm. Left hemithorax expansion 0.5 cm. Movement of chest wall. In left side, apical, anterior and posterior areas, movement of chest wall is reduced. Whereas in right side, movements are normal in all three sides. Vocal femmeters. So in supraclavicular area, on left side, vocal femmeters is normal, and in infraclavicular area, mammary, axillary, infraaxillary, suprascapular and interscapular and infrascapular areas, vocal femmeters are reduced. In right side, all areas are normal. Percussion. In left side, clavicle is resonant. Supraclavicular area is also resonant. Infraclavicular, mammary, axillary, infraaxillary, suprascapular, infrascapular and interscapular area are stony dullness.
One more thing is when you say percussion, say the number of space so that you can say whether it is a massive effusion, moderate effusion, minimal effusion. So it is above second space, he says massive. So in that case, that would be ideal rather than saying the areas.
On right side, it is resonant. Auscultation. In left side, supraclavicular area, normal vesicular breath sound. Infraclavicular, mammary, axillary, infraaxillary, suprascapular, infrascapular and interscapular areas have absent breath sound. And on right side, normal vesicular breath sound is seen in all areas. And vocal resonance. And left side, supraclavicular area, normal vocal resonance, and infraclavicular, mammary, axillary, infraaxillary, suprascapular, infrascapular and interscapular areas. Vocal resonance is diminished. In right side, all areas shows the vocal resonance normal, no added sounds. Systemic examination, CVS examination, S1, S2 heard and no murmur. Abdominal examination, soft and non-tender, no organomegaly. CNS examination, no focal neural disturbance.
Normal. In inspection or anything, you find a
Scar.
Scar should be, that you should have mentioned because you said renal scar, we should have looked for scar.
Summary, a 71-year-old Mrs. X who was treated for renal cell carcinoma 1 year back, presented with pleuritic chest pain, cough, loss of appetite, weight loss for past 2 months, breathlessness in 15 days. On examination, trachea deviated to right side, stony dullness on the left side, decreased movements, vocal femmeters, vocal resonance on the left side, absence of Breath sounds on the left side, no added sound. Provisional diagnosis, a case of left-sided massive pleural effusion, etiology metastatic in view of renal cell carcinoma with no respiratory failure.
Why you made a diagnosis of left-sided effusion and why you use the word massive?
Because
What are the findings which made you to think there is left-sided effusion?
vocal resonance, movement of cells decreased on left side,
Starting from the inspection machine.
Always you should start from.
trachea deviated to the
Which are
right,
take out the positive findings which supported the diagnosis of pleural effusion. No.
trachea deviated to the right side,
Care deviate to the opposite side. Why it's
intercostal
apex
widening,
beat not visible and not palpable. What are the conditions where the apex beat is not visible and palpable? Obese person. Obese is also not visible but it will be palpable most of the cases. I am asking what are the conditions where the apex beat is not visible and palpable also. Like this patient. What is obese? Two obese.
Massive pleural effusion.
Pleural effusion.
Right, then
Pneumothorax. Thick chest wall.
that I say already told you obesity.
Obesity.
Somebody
Behind the ribs.
Extra that as a postgraduate you should say always we should look for apex with both hands. Right, good. Anything else? Easy. Pericardial effusion, that you have to say.
Okay. So you are not getting the apex palpable in the normal space.
Also bulging is seen on the left side.
Left side there is a bulging.
Intercostal spaces are widened, sir.
Wider.
Then inspection and the chest up to movements, sir. Movements is reduced on the left side. All the movements are reduced. Then coming to percussion, we were having a stony dullness which is present from the infraclavicular area onwards, which suggests the massive pleural effusion, sir. And then the auscultation, absent breath sounds were heard. Then vocal resonance were diminished.
Lot of findings which are not specific of pleural effusion. Can you tell the findings which are diagnostic or specific for pleural effusion?
Stony dullness in percussion, sir.
First, tracheal tissue
Tracheal
opposite
shift to
side.
opposite side.
In pleural effusion, what is happening? Why is the tracheal shift is the opposite side?
Because due to the accumulation of the fluid in between the
So what is
pleura,
happening?
mediastinal shift will happen, sir.
Due to what?
Because of the pleura, in between pleural effusion, sir.
What is happening? The hemothoracic volume is increasing. Na? Why the volume is increasing in pleural effusion? What is pleural effusion? Abnormal quantity of fluid in the pleural cavity. So when the fluid accumulation what will happen? The lung will passively collapse. Initially the collapse will be proportional to the fluid. Gradually as the fluid accumulates more, the collapse will be disproportionate. The lung will not collapse as much as the fluid. If there is one liter, lung will not collapse. So the hemithoracic volume will increase. It will shift the mediastinum and trachea. Upper part of mediastinum trachea, lower part will be. So this patient always you try to palpate the apex beat on the opposite side also because it could be shifted to the opposite side. Before committing that I will not palpate. No? That you should be careful. Okay. Another finding also the right heart border. The left heart border will be merging with opacity. There is a chance that the right heart border will be shifted. These things the examiner will come and examiner will make you that you will find out the findings. So when there is a massive effusion on the right side, left side, this patient, trachea has to be on the opposite side, apex has to be on the opposite side, and the right heart must also have to be shifted. So that you recheck before giving your findings. Okay. So there are a lot of findings. Can you pick out the findings which are diagnostic of, for the pleural effusion? One is rectal shift to the opposite side.
Then there is hemithorax, expansion of the differential expansion of the hemithorax on the left side.
That's I am asking pleural effusion findings.
Stony dullness on
Stony
the
dullness.
absent breath.
Dullness or stony dullness, both are enough. but you are getting stony dullness. Okay,
Then absence of breath sounds.
breath sounds reduced or absent. You are getting absent breath sounds. But remember, most of the pleural effusion you will get near total absence will not be there. It will be some breath sounds. It will be reduced, but absence is also will take it. Then
Intercostal widening.
that can happen in pneumothorax also.
Then on
Finding
percussion.
sensitive pleural effusion.
On percussion.
Stony dullness you mentioned.
S-shaped.
Tracted to the opposite, stony dullness. Semi-thorax, that's 2 findings. Then one more finding which is vocal resonance, decrease, or sometimes it can be absent also, it is decrease. So these are the signs which help you to make it. So if the examiner asks, what are the findings by which you made a diagnosis of left-sided effusion, your answer is media should shift to the opposite as indicated by the rectal shift and effect on apex, that also. There is percussion which is stony dullness and decreased vocal fremitus on the ipsilateral side. So these are the signs of pleural effusion. Why it is massive? Sir was mentioning, when the percussion above the second phase is dull, it is massive effusion. What is the significance of picking out a massive effusion? Massive effusion is actually a medical emergency because it is shifting the heart, okay, everything to opposite. The patient cannot sustain for a long time. He may go for arrhythmia, for cardiac tamponade. So that's why you are. So when the dullness is above the second rib, use the terminology massive pleural effusion. Okay. In this patient, will you look for shifting dullness? Morning when we demonstrated, we did demonstrate and talked about 2 findings. One is shifting dullness, number 2 is succussion splash. You heard of that? With that 2 special signs we didn't discuss. Why? Because these are special signs. Shifting dullness, succussion splash, going sound, post-acid section, all these are special signs. One case was presented cavity. They look for post-acid section because they got a common breathing and they got a cavity. That is why they look for post-acid section. Like that, when you are getting fluid, it is very logical to think that whether the fluid is shifting or not. That is called shifting dullness. You need to look for that or not?
Sir, is the hydropneumothorax?
No, for how to identify whether it is hydropneumothorax. Unless you do that, you cannot identify.
If my diagnosis left-handed hydropneumothorax, without looking at that, how can you say?
There is a pleural effusion, you have to look at. Wherever there is a fluid, you should look for air. Wherever there is the air, you should look for fluid. The pneumothorax also, sometimes you will have pleural effusion also. As I said, open pneumothorax will have a fluid. So, whenever there is air, you should look for fluid. Fluid means air.
What that is correct. It classically occurs in hydropneumothorax. Okay. There you get resonance here and dullness here, and maybe you get a space like second group or third space, which is limiting the, which is the border where you get above resonance and below dullness. But all cases of dull pleural effusion, you have to look for the shifting dullness. It will be definitely present in hydropneumothorax, it will be absent. But books are saying you can get a delayed shifting dullness.
Late shifting. That is why we do X-ray chest in the lateral decubitus position. It will take long time. It will not shift immediately. It will take 10-15 minutes. Whereas hydropneumothorax, acute, immediately it will shift. So in which situation where pleural effusion with the trachea and midline are the same side?
Yes. I was about to ask that.
Sir, there is an mediastinal mass or pleural effusion is associated with some fibrosis or something, sir. Then if there is any tumor of
Think of pleural effusion as a diagnosis. Pleural effusion. That's what I
Yes, it is associated with some mass is there.
Mass is also space orientation. No. Mass of the fluid has to shift off to the opposite.
Along with fibrosis if it is present, sir.
Bilateral mediastinum is fixed. You can say fixed mediastinum.
Then bilateral pleural effusion.
Very good. The most common cause
small effusion. Unless you have more than 1.5 liters, there won't be any shift.
Locally pleural
Local
effusion.
effusion. Right, good.
So the most common causes are 2 for non-shifter mediastinum. Other than bilateral effusion, it's an extremely rare. Not extremely rare in cardiac failure and all you will get. So clinically, when you get a case for exam, when you get findings of pleural effusion as indicated by stony dullness, decreased PFAR, the mediastinum is not shifted. Think of loculated effusion number 1. Otherwise called insisted effusion. Number 2, small effusion. Mild to moderate effusion, mediastinum may not shift. Then other causes like fissure mediastinum, bilateral effusion, etc. A common question which is asked was exam. Okay.
What other findings she has missed? She has not mentioned. That is very important. One is shifting dullness she didn't mention. One more finding she has not mentioned is what? Succussion splash, right? Whether it is a loculated diffusion or diffuse effusion, how will you identify in the left side? You percuss drop space.
So we have to focus his drop space.
Did you say that? I don't know. That is very important. So, drop space is not obliterated with pleural effusion means what do you mean by that?
This loculated
One posterior loculation. That is the main thing. Sometimes even small effusion, it cannot be identified. So, a drop space is a must you have to do on the left side. That is a very important thing. On the right side, you have to do in case of tidal percussion has to be done in case of pleural effusion.
You got the bad points on mentioned. In pleural effusion, the first quantity of fluid or the first drop of fluid will accumulate the CPR, post-operative angle. Gradually it come up. But when you have a large pleural reflection, suppose a fluid collects here or back, what will happen? The CPR will be free. So you will get a resonance in the tidal percussion and in the top face also resonant. So when there is no shift of mediastinum, cross face resonant on the left side, or the here there is resonance, you make a diagnosis of loculated pleural effusion. That's also very important. Then, if at all you want to do a shifting dullness, that you are supposed to do in all pleural effusion. How will you do it? Can you just,
in the axle.
we don't have patient to demonstrate, you can just tell.
We basically put an axle as well. Focus in the axle, then where we get the dull, we'll ask the patient to turn to the opposite side and wait, and then we'll again wait for 30 seconds, and then we'll again focus. The area of dullness will turn again this way.
So, what she is telling, you find out the upper level of dullness first. Percuss, resonant, oh, it's dull. What you do is you keep your finger there itself. That's very important. You take your finger, ask the patient lie down, go. So you have to keep your finger there still. As the patient lie down, you also move along with the patient. Then wait for 5 to 10 seconds. Then it has to be in the mid-axillary line, not here. So percuss out, keep your finger there itself, ask the patient turn on the opposite, wait for 5 to 10 seconds, then you percuss. Suppose that area which was dull is resonant, then you can say the fluid has shifted. That should happen within 5 to 10 seconds. But if it happens more than 20 to 30 seconds, that's called a late or delayed shift. That can happen in pleural effusion. If you take this patient and allow 30 seconds, 1 minute, then the fluid will gradually go to the dependent partner. You may get some resonance. So, a immediate resonance after changing the position is called a shifting dullness. If shifting dullness is positive, then you have to do. So, when you get stony dullness, look for shifting dullness. When shifting dullness is positive, look for. That is why these are called special signs which you need not suppose to look in all patients. If one is positive, look for the other. You got it?
The other thing is when you are eliciting succussion splash, what I used to suggest my student is ask the patient lie down so that the air fluid interface will be more. If you shake like that, the succussion splash will be well there. That is, for example, color bottle. If you shake the bottle, the sound will be very less. Whereas if you keep the bottle like that, the succussion splash will be well done. That is one important thing. The other important thing she should have asked for or she should have mentioned is PG, cholunga. On auscultation, you should have identified one more point.
Egophony above the level.
She said initially the patient had pleuritic type of pain, so she should have looked for pleural, at least above the level of the pleural effusion, where the both parietal and visceral pleura may join. In that place you have to look for. She should have told that because she said the patient had pleuritic type of pain. So you should have looked for it, and otherwise you should have told that there is no pleural effusion above the level of pleural effusion, because at that stage where the parietal and visceral pleura will meet against each other.
So there are signs, what sir is telling, there are signs which can come just above the pleural fluid. Suppose the second or third space is your upper level of fluid. Above that you can get some signs. One is called ego fluid. Other one is sometimes you may get rub, sometimes. But when fluid comes, usually the rub disappears, but sometimes you can. But you have to look for before giving your missing physical findings is not actually a good thing in exam. So what is ego phony? What is ego phony?
A to E sign. A to E sign.
E to A or A to E? E to A. What is ego phony? E to A.
When the patient is we ask a bit about the level of effusion.
Ego phony is a type of bronchial breathing where there is a bleating quality, or when the patient say E, you will be heard as A. That is. What is the mechanism? Any idea? I think that is too high for you. Why that happens for the fluid? Before that, this patient has a decreased vocal resonance, you said, no? Almost absent. Diminished on the left side, above the fluid. But all books say fluid is a very good conductor of sound. But in pleural effusion, the vocal conductor resonance is decreased. Why?
The transmission of sound the fluid through the chest wall, the transmission will be reduced, so that's why it is decreased.
But still you have a passively collapsed lung there, the sound has to conduct some sound to cut down. One thing she is correct, because the lung is collapsed, the sounds are less. Number two, there is collapse and there is fluid. Okay, the collapsed lung is air containing and this is fluid. Two are two different medium. The sounds will reflect at the air fluid interface. So the fluid is not getting any sounds to conduct. If they get, they will definitely conduct because fluid is 20 times better conductor than lungs and air. So the reason of reduction or absence of VR in pleural effusion is two. Number one, the collapsed lung is producing less sounds. The VR, how you are doing the VR? You are asking the patient to say 1 1 1 1 2 3, no? 1 1 1 1. That much sound is, even the collapsed lung will conduct sound. But at the air fluid interface, air in the lung and fluid is like a barrier, no? There the sounds will reflect back. All the sounds will be reflected back. That's why you are getting a decreased VFR above the fluid. But what happens above the pleural fluid level? At the fluid, you will get a reduced VFR because of this mechanism. Above the pleural fluid level, what happens? There also we have a thin layer of fluid. Thin layer of fluid above. It's not absent. That thin layer of fluid will act in such a way that it will reflect the high frequency sounds and low frequency sounds are conducted. That is why the A is being heard as E is being heard as A. That is the mechanism. I think that may not be required for an undergraduate level, but just understand that. What they are asking, you can answer. Okay. So,
When will you have a bronchial breath sound in pleural effusion? Postgraduate. Can you have a bronchial breath sound in pleural effusion? If it is so, it will be heard. When will you have it?
Tubular breath sounds above the level of pleural effusion.
One name.
Connection bronch.
Sarah has given one answer for that also.
Bronchopleural.
Patent bronchus.
Bronchopleural fistula. Bronchopleural.
Tense pleural effusion. Sarah said when there is a air interface, air and fluid interface, it will not be reflected. It will be reflected, it will not be conducted to the chest wall. When it is tense pleural effusion, sometimes it happened. I have seen such cases, when there is only one interface, bronchus with complete collapse of the lung. So there will be bronchus and fluid only. So fluid is a better conductor. So it is conducted. So you will have a bronchial breath. So for that they used to say, one example is when the American War of Independence, at that time there was not no communication between. So when the war was fought by Americans and British people, they used to go under the water and they will bang the hull of the ship. So that will be transmitted to the another ship. They will go inside the water and they will listen to the sound. That is why they have done a communication during American and British War of Independence. So that is the one important thing, where tense pleural effusion, where you will have bronchial breath sound. Other thing is above the pleural effusion is third is sometimes pneumonic effusion, very rarely can have a bronchial breath sound.
I think that is a point for your undergrad level. When there is a pleural effusion which is minimal and you are getting a bronchial breathing, if it's a high pitch, it is sure that the etiology of the pleural effusion is a consolidation. So the lung consolidation is producing a bronchial breathing. The pleural effusion you are getting the other findings. So pleural effusion is associated with a bronchial breathing. Then first cause would be like a consolidation and breathing, like pneumonic effusion. The other causes also can be taken into account. Do you have any differential diagnosis for this patient? My diagnosis is a large mass lesion on the left side. What is your point against the mass lesion?
Stony dullness is here, sir. And also,
Okay. In mass lesion, usually you get a dullness. Here you are getting a stony dullness. Okay.
and also in mass there will be shift of trachea is mass. Then
Mass also pretty soft. Mass compression collapse only then.
so breath sounds.
That sounds also pretty similar. The vocal resonance and primitus will be increased in mass lesion. The finding which differentiate between mass and pleural effusion is dullness in mass, stony dullness in fluid. VFER will be reduced in pleural effusion, will be usually increased. Another explanation for no shift of media cinema, which we discussed earlier. In pleural effusion, what is happening to the lung?
Lung is getting
Lung is passively collapsed, not actively collapsed. Suppose there is a bronchus obstructed with a tumor and there is an active collapse. The collapse will produce shift of media cinema to the same side and pleural effusion will produce shift to the opposite. So you get a trigger trachea. So one of the cause for pleural effusion with a central trachea and media cinema is associated active collapse. Active collapse. That's also possible. Okay. So left-sided massive effusion. All agree? All agree? Is it a left-sided mass? No. Because of the decreased VFER, stony dullness, we will agree this massive effusion. The etiology she mentioned is metastasis in view of renal cell carcinoma. Yes or no? Possible etiology could be that. What are the points to support this etiological diagnosis? My etiology is tuberculosis. Your is malignancy. What are the points to support?
So in case of tuberculosis, in this patient there's no fever, there's no evening.
Absence of fever is one point.
There's no evening rise of temperature in this patient.
Okay.
And also this is very massive, suggesting of.
Whenever there is massive pleural effusion, the first thing comes to your mind is malignancy. It can occur in tuberculosis also, but the first DD has to be. So you can explain. I am thinking the etiology because of previous history of RC's renal cell carcinoma, because of massive pleural effusion and absence of fever. Absence of fever. I thought etiology, possible etiology is a malignancy, and with evidence of no respiratory failure. So that is it. Any questions to be asked?
What is the mechanism of pleural effusion in case of tuberculosis?
Tuberculosis basically is an X-rated variety of pleural effusion in tuberculosis. Basically in this, it can be due to the seedling of this or lymphatic obstruction can be produced, which leads to tuberculosis, and also there will be increase in the pulmonary vasculature, permeability can increase, leading to pleural effusion, sir.
In case you should tell what is the common cause of pleural effusion mechanism. This is one reason, but it is not the main reason.
That is why pleural flow is usually negative for
Negative for
AFB. We are not even getting AFB for
CV net will be negative in case of tuberculosis. That is why we don't rely only to 20 to 30% will be positive. Then what is the mechanism? Why we are not able to get the organism in the pleural effusion.
The commonest mechanism of development of tuberous pleural effusion is that it is with the hypersensitivity mechanism to the tuberculosis.
That is why we CD not always, not always, only 20 to 30% will be positive. Rest of the time, that is why we don't send the pleural fluid for CD not. Or culture. Culture will be very rarely positive, 20% positive. How many percentage of they will have sputum positive? PG then only.
The pleural effusion is of tuberculosis etiology.
Usually they will have associated parenchymal. How many percentage of them will have parenchymal?
In this tuberculosis, what percentage of the sputum will be positive?
Positive. Anyhow, pleural effusion will ask for a sputum AFP also. Europa? 20 to 30%. How will you confirm the diagnosis?
So in this case,
This
so first we can go for an X-ray, sir. In the X-ray we can see the Ellis S curve. Basic, in case if you have to find it in a very low level, you can go for UST, which can detect almost like 50 ml range. In X-ray, 200 ml is
can you
needed.
describe the typical X-ray of a pleural effusion?
Sir, its blunting of the costophrenic and the cardiophrenic angle will be present. Ellis S curve will be seen in axillary area, it will be more.
Very good. So you will see a homogeneous opacity, obliterating in the costophrenic and cardiophrenic angle with a high level in the axilla, which is called the X-ray curve of Ellis. Everything is present. Which test can confirm your etiology? X-ray is taken, there is massive effusion on the left side. So, which test can confirm the etiology of your
Chemotherapy and aspirate, cytology, lights criteria.
That will tell you only X-ray.
X-ray.
Your etiology is metastasis. So you have to prove that.
Malignant cells in the pleural fluid.
Otherwise,
Cytology we can go for the pleural fluid.
That is malignant cells.
pleural.
Pleural.
Initially we were doing blind pleural biopsy. Now we have a medical thoracoscope. We can identify the site of the inflammation deposit. We can get the biopsy from that area.
So the etiology is malignancy. You can call, and one way you can call this say malignant pleural effusion on the left side. The best diagnostic is to demonstrate malignant cells in the pleural fluid or malignancy of the pleural biopsy. So anything really is okay to confirm your diagnosis of malignant pleural effusion. If these malignant cells are positive in this pleural fluid, do you think this is an early malignancy or an advanced malignancy?
It's an advanced malignancy.
So any pleural effusion, all malignant effusions are metastatic.
Stage 4.
Stage
It is an advanced stage of malignancy. My last question: what are the primary in a female from where we can get malignant pleural effusion?
breast,
Breast, very good.
ovaries,
Ovaries,
lungs,
lung itself, very good, excellent. Then your case,
RCC,
renal cell carcinoma, ovarian carcinoma,
lymphomas.
lymphomas, very good. So these are the common. Lung is the commonest one in males. Breast is the commonest in females. Another is GIT, ovary, renal cell carcinoma, and other causes like lymphoma.
For PGs, what is pseudo exhibit? You find out and send a message.
Nicely presented.